Assalamu alaikum. I'm Dr. Muhammad Ali Rabani, and today on the platform of Medicals Academics, I'll be discussing the part 1 FCPS part 1 review questions. And for the today's video, we'll be discussing the topic head and neck. And I'll be discussing the questions from the pool SK Golden 9 Medicine and Allied. Bismillahirrahmanirrahim. And before starting, I'd like to start with the quote that I have seen further. It is by standing on the shoulder of the giants. So I'll thank you, all of those who made me what I am today, and whose content and illustration and other material I will be using as the helping material. And I don't claim my ownership to any of the material that is not mine, and the due credit will be given to the original source to the best of my capability. So, for the purpose of today, I'll be dividing the topics into these further regions. We'll discuss osteology, question wise, divide the questions in the head region, neck region, nerves, vessels, and the questions for the back. So, let's start with osteology. And before starting, I'll show you that any question mentioned here will have a source at the bottom, and any picture that will be given will also have a source at the bottom here. So the first question is, and these are the original question numbers that are present in the source material. So for the skull and cranial cavity, so accessory meningeal artery passes through which foramen? So here answer will be foramen ovale. For this particular thing, I would like to emphasize that the structures that are passing through the foramina has been asked very repetitively, especially the cranial nerves from which foramina of the skull they are exiting, and the vessels, especially meningeal artery and accessory meningeal arteries like this. So be very vigilant about the MCQs regarding that, regarding the structures passing through the foramen of the cranium. So accessory meningeal artery, it passes through foramen ovale. What other structures pass through foramen ovale? That is mandibular division of trigeminal nerve. And the another question that is repeatedly asked is what meningeal artery, middle meningeal artery passes through? Middle meningeal artery passes through foramen spinosum. You can see it here. So, which of the following is transmitted through foramen rotundum? You should know that it is passing the maxillary division of the trigeminal nerve. Be very vigilant about the three division of the trigeminal nerve. So, it is passing through the foramen rotundum. You cannot see in this picture, but still. So, there is questions about mandible and temporomandibular joint. There are a lot of questions about temporomandibular joint regarding its stability and the movement that muscles of mastication produce about them. So mandible is stabilized by which joint? So here is only one ligament is given, and this ligament is the most important one in stabilizing the mandibular joint. So the correct answer is temporomandibular ligament. You can see it is also known as the lateral ligament. So if you are asked given this option rather than this, be vigilant and don't get it wrong. So these are the muscles of mastication. They have a role, but this is the most important one, temporomandibular ligament. This question has been repeated multiple times. Stability of TMJ, capsules, sphenomandibular ligament, stylomandibular ligament, temporomandibular ligament. I do focus that all of these did do contribute to the stability, but the most important one is temporomandibular ligament or the lateral ligament of temporomandibular joint. Then, and there is a question that is asked very repeatedly: hide bone. What is the level of the hide bone? Hide bone is at the level of C3. You should know that. Okay? Hide bone is the level of C3. It has been asked in September 19, morning paper, medicine allied, November 20th, morning paper, evening paper, and 21st morning paper. It has been asked repetitively. And the other landmark about regarding this is just below the hide bone, there is start of trachea, larynx, basically before trachea, and the uppermost part of the larynx that is palpable, especially in the males, that is the upper margin thyroid notch, the upper margin of thyroid lamina, that is basically at the level of T4. And that particular question is being asked usually in the backdrop of what is the level of bifurcation of common carotid artery. Common carotid artery bifurcates at the level of thyroid cartilage T4. So vertebra and joints. In the forced flexion, flexion is when you put your head forwards, जिस तरह हम उर्दू में कहते हैं सर तस्लीम खम करना, सामने की तरफ से झुकाने से. So which ligament will be torn? So here the correct answer will be ligamentum nuchae. Here you can see that here is the a picture from the neck. This picture has been taken from lateral anatomy. This is the anterior aspect. This is the posterior aspect. For the flexion purpose, the head will flex like this forward. When the head comes like this, the most stretched ligament will be this ligament that will be lengthened in the response to the flexion, and by lengthening, it can be torn in case of it is overworked. So there will be ligamentum lucky. And if you go for hyperextension, if you move the head to the back, the ligament that is most anterior to it, this one is anterior longitudinal ligament that may be involved and torn, which keeps the vertebral bodies in place. So I have a little objection for this question. The question that has been given, the answer that has been given in the key is ligamentum flamum. So it is right. It is very much understandable that ligamentum flamum that connects the two lamina of the conjunctive vertebra that is very much supporting. But the objection is that I say that there are three ligaments that are very strong and are very important in maintaining the things. This is anterior longitudinal ligament, there is posterior longitudinal ligament, and then there is ligamentum flamum. And even in the question pool books, you can see the answers circulating between these. In some question, the same answer will have an answer different. So that is because in most of the cases, these three are the ligaments that are key in keeping the vertebra together. So in there is usually sometimes there is a recall bias, so it happens, and if you have any one of the answers, it will be right. So for me, this particular question, it also has longitudinal ligament, and they also have a very important role in keeping the vertebral body in place. But for the purpose, ligamentum flamum is right also. So in here, the question that is highlighted, just it is the key that is given in the original source, and with the red highlight, that is the answer which I also think that is also correct. So there is no more. There is only one or two questions. With this, I agree with most of the questions. So LP needle pierces some ligament. For that particular thing, for the purpose, you should remember all the layers that are encountered from skin to the epidural space as the LP needle passes to the ultimately to subarachnoid space. All the layers you should know. So ligament, there is one ligament in the pathway that is ligamentum flamum. So you should know. And there is further skin, then superficial fascia, then before going there is supraspinous ligament if you're exactly in the midline, and then there is interspinous ligament if you're exactly in the midline, and then there is ligamentum flavum we saw in the previous one. After that there is epidural space that is between the periosteum and ligamentum flavum, and then there is a dura mater, and then there is dura mater itself. It is shown here somewhat in purple, and then there is arachnoid matter, it is shown somewhere in red, and then there is sub arachnoid space. So when you are giving spinal anesthesia, you are mostly trying to reach subarachnoid space for the lumbar anesthetic. Sometimes you go to the epidural space also. So this question is also asked, the epidural space is present between which layers? It is between the dura mater in the inside and the ligamentum flavum or periosteal layer on the outside. So this is the question that has been asked. Moving on to the questions in the head region. So there is a question that lower lip bleed, how to stop. For that, you should know the arterial way of the head and neck, basically the face, and you should know that lower lip is supplied bilaterally from the facial artery and the freely anastomose in the midline. So here are the questions that can be get confused are from this one and this one. So whenever you want to stop bleeding in the face, you should stop both arteries, because both of the arteries that are supplying the lip, they anastomose freely in one another. And if there is a cut on the left side and you block the artery on that side, the lip still bleeds because the anastomosis branches from the opposite side supply to the bleeding opening. So whenever there is question about stopping the bleeding, it is always answered is compressing facial artery from the both side. And another question is asked, where to compress the facial artery? The facial artery is compressed at the lower angle of the mandible, lower margin of the mandible, just anterior to the insertion of the origin of the masseter muscle. And here is the notch is also present. The pain from the orbit to mouth is carried by. It is basically being asked what are the three divisions of the trigeminal nerve that supply the face. You should be very clear about that. Orbit to mouth is from the maxillary division of trigeminal nerve. Just to give you an idea, upper eyelid and forehead is from the branches of ophthalmic division. Lower eyelid and upper lip and any region between them is from the maxillary division. Lower lip up to the chin, it is mandibular division. And mandibular division, it goes back to the front of the ear, external ear, and all that. If we have any lecture on the head and neck, we can discuss this in detail. But this is the general idea that you should have in mind. So, a part pin from orbit to mouth, it has been labeled on orange color in this picture. It has been carried by maxillary division of the trigeminal nerve. Corneal reflex. So this is a very frequently asked question. Corneal reflex is one when there is a touching of the surface of the cornea or blowing on the surface of the cornea and a person blinks in response. So, afferent component, the sensory component, is by which nerve? It is by trigeminal nerve. It is a very simplified question, good for the people who had them, but some people get a more difficult one for that particular. How? The corneal reflex is being carried by, sorry, here you can see that these are the ciliary nerves, and these ciliary nerves go to the nasociliary branch. That nasociliary branch is ultimately the branch of ophthalmic division of trigeminal nerve. So the question may be asked on either level. You can be asked to give an option between ophthalmic division, maxillary, and mandibular division. There you will have to pick up the ophthalmic division, corneal reflex after. And the question can go into the further detail about the branch of the ophthalmic division that is actually carrying out the reflex. So it will be nasociliary branch of the ophthalmic division of trigeminal nerve. And while we're on the subject, you should know the efferent component. So the efferent component, the motor component, is being carried out by the facial nerve, and facial nerve leads to the contraction of the orbicularis oculi. Blurring vision in exophthalmos is due to, when there is exophthalmos, there should be anything, the mass, a pressure, anything that is behind the eye that has led to the protruding of the eye. So blurring of vision in that case it will be the pressure on the optic nerve. So whatever the reason that leads to the pressure in this retroorbital area and this area, this ultimately this also affects the orbit optic nerve that is entering and compressing, and that leads to the blurring of the vision. Diplopia. Diplopia on looping downwards. There is a, and they have said that it is a poor recall question. Diplopia on looking downwards and loss of ipsilateral sensation. So this particular component, it is very much give answers. When we can look downward and there is a diplopia, this means that the affected eye is unable to look downwards. So the healthy eye look downwards, affected eye does not, and the two eyes, the image in the two eyes do not match each other, and diplopia occur. So the uh, reason usually for the unable to look downwards is that paralysis of the superior oblique muscle, and it is being supplied with the cranial nerve number 4. So you should know the clinical examination of the eyes. It has been very much asked. For example, from medially and downwards, the muscle that is most important is superior oblique. So here is this. Again, it is said that it is poor recall question. It does not explain the loss of ipsilateral sensation. So we won't be discussing that because it is not very much made clear in the question. In the original question, it must have been justified in some way. A patient cannot rotate his eye from adducted position. To rotate the eye from the adducted position, you would need to abduct the eye. That is the function of lateral rectus. See again the same picture. You should remember this. Moving the bus will stimulate. If you move the bus, you are actually doing horizontal acceleration, horizontal movement. You should know that horizontal acceleration is by the ventricle, and the vertical acceleration as you move up and down in a lift, it is from secure. So the correct answer in this case is vertical. And the semicircular canals are basically giving sensations for the rotatory movements. If you say no, you move your head from left to right when you say no. Like you are, this is one plane, horizontal plane. If you are moving as you say yes in a nodding head inflection and extension, that is other rotatory movement. And the third one in the coronal plane will be that if you um, tilt your head to one side, then tilt your head to the opposite side. This is the movement in the uh, coronal plane. So these are the three planes of movement. These rotations are basically being carried out in the semicircular canal. The horizontal acceleration utricle, the vertical acceleration or movement in saccule. And another one is that utricle and saccule, they give idea about the static position. Just like if you're sitting now in your seat and listening to the lecture, you consciously, subconsciously know that you are sitting. That is being carried out by the vertical and secure also. And there's dynamic movement that is being carried out by the semicircular canal. Forward movement in the burst, but will be accelerated. Again, the same question, vertical. Bone conduction is better than air conduction. I suggest strongly that you give a read whenever you are reading the topic of air conduction, bone conduction. Do read Ryanese and Weber test. So bone conduction is better when there is some difference in the air conduction. There is a conduction difference, so it will be lateralized Weber test. So Weber test is here. Weber test is one in which prong is put on the vertex of the hand, and normally what happens is if uh, air conduction is okay in both here, we hear echo sound in both here. If there's a conducting loss, let's say in this ear, there is conducting loss, eardrum is ruptured. Now, this air will receive the vibrations predominantly from the bony vibrations, and this air will be hearing vibration from the air conduction. So, you will have a lateralized Weber test. You will be hearing more sound in this ear. So, it will be a lateralized Weber test. Rhine test, we'll talk about it whenever you can, but not right now. Nasal cavity and paranasal sinuses. Premolar tooth extraction. After that, a facial swelling and nasal secretions they occurred, and route of infection is that. You should know the relation of the teeth to which sinus, and the very good example is maxillary sinus, just above the upper teeth, especially the molars and premolars. There is maxillary sinus, and especially the bone that is separating the two, it becomes thinner and thinner with age. And in very old people, there may be no bone at all. There may be just a layer of mucous membrane. So maxillary sinus tend to get infected in the molar extractions and premolar tooth, molar and premolar tooth extractions and infections. Same question again: upper molar tooth extraction, face swollen, nasal discharge, sinus, maxillary sinus. Small unnamed glands in the oral cavity is in the layer. It's related to the histology. You have so much to in first year, part one. You don't essentially get the time to read all of the histology. So I'll make it simpler for you. There is mucosal layer that includes epithelium, lamina propria, muscularis mucosa. Then there is submucosa. Then there is muscular layer, and then there are other layers. So the glands that are present in the oral cavity are mostly in the submucosal layer. Here it been shown in the picture. We can have a detailed discussion if we're studying histology. Let me know. Parotid region. Facial nerve after passing through stylum foramen is what relation to the parotid gland. Just immediately after imaging from stylum foramen, you should know that stylum if we just try to get an idea, if you palpate your external ear just and in front of the tragus, there is zygomatic arch. The parotid gland is present in front of the ear and below the zygomatic arch, parotid gland. And behind you can feel the mastoid prominence, the mastoid tuberosity. So basically, stylum mastoid foramen is present on the medial aspect of that mastoid tuberosity. So now you can see that parotid gland is in the front, and behind the ear mastoid prominence and the stylum mastoid foramen, it is behind. So facial nerve is posterior to that relation, and from the posterior aspect, facial nerve comes forward and it enters the parotid gland later in the posteromedial aspect. Temporal and infratemporal region. Question is, the patient cannot chew. The muscle is tender on palpation. So for that purpose, you should know the functions of the muscles of mastication, and for chewing purpose, you should know that the elevation of the jaw is the most important one. You can even right now sitting, you can just clench your teeth, put a hand on your face, and you will see the masseter tightening. So the and of course there are other muscles that are involved in closing of the mouth, medial pterygoid, but the most forceful and the temporalis. All three muscles they do help in closing of the mouth, but the most powerful one and the most superficial one that will be felt easily tender on palpation, that will be masseter. So you can see that elevation has all three muscles, but we will go for masseter as it's most powerful one in this particular case, and it's easy to palpate. Okay, now there is question about a patient can open his mouth with muscle damage. You should know what are the factors that help in opening the mouth. The simple one is it's the gravity. If you just relax the muscle that is closing the mouth, the mandible will fall down with the gravity. But for the forceful opening, there are muscles that are on the underneath, and that are basically the suprahyoid muscles, the digastric, the mylohyoid, the genohyoid, and these are the muscles that pull down the mandible. But the thing that is often forgotten is that the lateral pterygoid, its actual function is yes, its actual function is protraction. It's moving forward of the mandible, but while it moves the mandible forward, it gives the mandible in the proper place in the temporomandibular joint so that it can move down. So for opening the mouth, the first the lateral pterygoid has to pull mandible a little forward, and then the mouth will be open. So if there is a difficulty in the, or a problem in this lateral pterygoid, a patient will not be able to move his mouth. So you can see that depression, you can see yes, in depression there is no muscle, lateral pterygoid is not mentioned in most of the textbook. But what happens is that the lateral pterygoid, when it pulls forward, it gets the mandibular, um, the head of the mandible into a proper place in the mandibular fossa so it can have a mechanical advantage in opening in the mouth. Moving on to the questions in the neck, this is a very repetitively asked question. You should know very much about the fascias of the neck and what are the different layers that are, for example, externally there is superficial, then there is deep fascia. Deep fascia has further investing layer, pretracheal layer, infrahead layer, buccopharyngeal fascia, prevertebral layer, carotid sheath. You should give a read about to these topics, and mostly the question asked is about the what are the structures in the pretracheal fascia. See, the thyroid gland here it is shown in the blue color in this particular picture. Pretracheal fascia, that is the visceral layer of cervical fascia. It encloses the thyroid gland. This one asked multiple times, and by the way, this is a typo. Peritracheal fascia. It is the actual spellings are pretracheal, Pretracheal. So this has been questioned multiple times in the posterior triangle of the neck. Yes, and the contents, the posterior triangle of the neck is again further multiple times asked. The question that usually asked is the muscles that are forming the boundaries and the contents of it. And again, there's everything. And then there is a muscles that are forming the floor. That I have not seen that question much, but the structure that is forming the roof. The structure that is forming the roof is asked here. The posterior triangle of the neck is covered by, and in that case, it is the deep cervical fascia. And to be more specific, it is the investing layer of the deep cervical fascia. So it is the point between this and this, sternocleidomastoid and the trapezius. And here you can see that the investing layer of deep cervical fascia runs between encircles whole of the neck, and within the layer is sternocleidomastoid and trapezius. So this region, this is the roof of the posterior triangle. The investing layer of deep cervical fascia shown in red from the sternocleidomastoid to trapezius. Axillary sheath is a continuation of which fascia? It is the prevertebral fascia. Thing to remember is that prevertebral fascia encloses the spinal vertebral column, spinal cord, and all of the muscles surrounding them. So all of the nerves that exist the vertebral column, they have to first enter the prevertebral fascial sheath, the cavity in the prevertebral space, and from here they have to exit. And when they exit into the axilla, they take a part of fascia with them in the form of axillary sheath. Regarding carotid sheath, the answers are given that extends up to the adventitia. Yes, carotid sheath from the upper margin it starts around the attachment around the openings where the internal carotid artery, carotid canal opens, and internal there is jugular vein opens. And if you follow down, here it is shown in the green color. If you follow down, it merges with the adventitia of the great vessels. So in case of carotid, it is the aortic arch. And the second thing that is frequently asked about them, what are the contents of the carotid sheath? So you should know internal jugular vein, um, carotid artery, internal carotid above, common carotid below, and vagus nerve between them throughout the length. And then there is deep cervical nerves. But the thing that is forgotten sometimes is that in the uppermost part, the other nerves, that is 10, 11 nerves, that is 10 is vagus, already said, 9 glossopharyngeal and 11 accessory nerves. In the uppermost part, they are a part of it, but they exit soon as they move down the neck. But vagus nerve, it moves all the way down through the neck into the thorax. A swelling on anterior part of the neck moves with degglutination. It is enclosed in. So you have to break down the question: swelling in the anterior part that moves with degglutination. So the swelling that moves with swallowing, it basically is should be um, uh, thyroid gland, and the thyroid gland is then the thyroid gland is enclosed in which layer? Again, the same answer: prevertebral pretracheal fascia. The marker has been a little off here. Appropriate function of sternocleidomastoid. For the purpose of part 1 examination, you are very rarely asked about the attachments of the muscles. Very rarely. It is once in a blue moon. What you are asked is basically the nerves supplying the muscles and the functions of the muscle. So the sternocleidomastoid helps to look towards the opposite side. Landmark muscles of the neck, again, it is sternocleidomastoid. And in some instances, you will be asked about the muscle that is scaling anterior muscles. So if we are talking about the root of the neck, we will be talking about scalene anterior. But here in general, sternocleidomastoid, because it is dividing the triangles into anterior and posterior, and there are so more other relations that are given in detail in the review snell also. Nerve supply of the hide bone. Remember, muscles, nerve supply, muscle function. That is facial nerve. Gunshot wound to the cervical region, which muscle will be paralyzed? It is basically a little vague question, and preferably speaking, it should give account about which triangle has been hit. So anterior triangle or posterior triangle. So here we'll see that if we'll assume that if nothing is mentioned here, we'll assume that anterior triangle is hit on the anterior surface of scalenus anterior. There is phrenic nerve. If phrenic nerve in the cervical region is damaged, there is a loss of paralysis of diaphragm. Now what happens is in the posterior triangle between the sternocleidomastoid and trapezius, this posterior triangle is traversed by accessory nerve. If in the posterior triangle there is a gunshot and on a stab wound or even neck surgery in the posterior triangle, the nerve that is most likely to be damaged is accessory nerve, cranial nerve number 10, and that leads to the loss of trapezius. And in trapezius, there will be loss of overhead abduction and combing action and shrugging of shoulders and all that. So that option was not present at all. So it gives us a very good leverage. The nerve damage will be phrenic here, and the muscle will be diaphragm paralyzed. Thyroid lies in, again, same question, pretracheal fascia, which lies medial to the thyroid. Again, I've been showing the picture of the netter again and again. You should study that picture at least once, which is a structure that are medial to the thyroid. Anteriorly, there is trachea. Above, in the higher region, there will be larynx. In the lower region, there will be trachea. Posteriorly, in the higher region, it will be pharynx. In the lower region, it will be esophagus. But the important thing is this: the nerve that is passing between the trachea and the esophagus, that is recurrent laryngeal nerve. So it is in the medial relation to the thyroid gland. Same question again and a bit. I have copy pasted all the questions that have been asked, whether they have been repeated or not. So it may give you an idea about how many times the question is being asked. Thyroid level is about C5 to T1. You can see the thyroid gland cannot be, simply speaking, it can be a MCQ of exclusion that thyroid cannot be at a single level or even at two levels. During thyroidectomy, posterior part of gland is left to preserve. So posterior part of gland is left to preserve. There is parathyroid gland embedded in the middle aspect and the lower pole of the posterior aspect of the thyroid gland. So parathyroid gland to preserve thyroidectomy, they should be preserved. So calcium metabolism, and you will learn about their exact physiology in the physiology department. So the neuromusculature, I'll be discussing cranial nerves here. I'll be discussing the lesions of the cranial nerves, but actual nuclei, that part will be included in the brainstem, and that will be in the part of the next video. For these particular exams, Golden 9, Medicine and Allied, and there was no question about the olfactory nerve, I'm sorry, and the cranial nerve number 2 and visual pathway. So the visual pathway should be very clear about, very clear cut concepts you should have. So it has been asked from all the angles. The lesion at the optic chiasm, here in the lesion number 3 optic chiasm, it leads to the loss of both nasal fibers and it leads to the both eyes temporal field of vision by temporal hemianopia, and you should know that it is heteronymous hemianopia. May have bitemporal heteronymous and bitemporal homonymous. You should know that it is bitemporal heteronymous. Bitemporal hemianopia, again same question. So it will be lead to the by the lesion in the middle of the optic chiasm. Here lesion number 3. This question is asked another way in this. The optic chiasm, anatomically speaking, it is just present above the pituitary gland. So any lesion that leads to the swelling of the pituitary gland, mostly it's neoplasia, it leads to the effect on the optic chiasm present above. So a woman having prolactinoma, problem with peripheral vision due to. If a woman has prolactinoma, the structure involved is pituitary gland. When it expands, it compresses optic chiasm, and here the peripheral vision is affected because there is bitemporal loss of vision in case of the middle fiber of the optic chiasm. All optic nerve fiber terminate at there are after optic nerve, there is optic chiasm, optic tract. Ultimately, there is the terminate and the lateral geniculate body right here. Lesion distal to the optic chiasm, that means the optic tract and or lateral geniculate body and optic then radiations. If anything of them is affected, both eyes will lose the half of the vision on the opposite side. For example, if there is a left side optic tract defect, there will be loss of right-sided vision. So it will be right homonymous hemianopia. Ptosis, mydriasis, anisocoria, horizontal gaze diplopia. All of these are occurring due to oculomotor nerve. Why? Ptosis due to the loss of supply of levator palpebrae superioris. Mydriasis because constriction of the pupil is not possible because the parasympathetic fibers were coming through the oculomotor nerve. Any sequoia, it is the unequal size of the pupils due to the same reason said here, and horizontal gate diplopia because the medial rectus is now not functioning, the lateral rectus will overcome and the eye will deviate towards the lateral side. So answer will be oculomotor nerve palsy. Which nerve causes the drooping of the eyelid? Again, I said like that levator palpebrae superioris by the oculomotor nerve. Lesion of the fourth nerve diplopia. A fourth nerve, its basic function is the looking downwards and outwards. So the question mostly asked about is the looking downwards diplopia, that is downward gaze on adduction. See, downwards and downward gaze on adduction. Be very vigilant that the directions that are given in this picture are given for the clinical testing. Downwards on medially, downward gaze on adduction. And the clinically, these are checked in H pattern. This is the pattern, but the actual function of the muscles, these are a little different. So be vigilant about that. Actual action of the muscle is downward and outwards. I'll not go into the much detail here, but you should look it up. The facial nerve, after passing through stylomastoid foramen, has what relation to the parotid gland? We discussed it in the parotid region also. It is the related posterior. By the way, the facial nerve, it's a very important nerve, and I have made actually this. You can take a screenshot of it. I have taken a different parts of the cranial nerves and where it passes. You should read it in detail. It originates from pons, enters through internal caustic matrix into the petrous part of temporal bone, passes above the internal ear, reaches the lateral aspect of the inner ear or the medial wall of the middle ear. Here there is an geniculate ganglion. At the geniculate ganglion, one branch exits, that is greater petrosal nerve, and greater petrosal nerve through various divisions ultimately reaches through the pterygopalatine ganglion, and from there it supplies the lacrimation process and the glands present in the nasal and palatine mucosa. Then in the middle ear, it passes in the wall, first in the medial wall, then in the posterior wall, that is the facial canalicus. And first, it gives rise to the nerve of stapedius that supplies the stapedius muscle and it leads to the dampening of the sound. Then in the posterior wall, it gives rise to the chorda tympani branch that passes through the middle ear, exits through good, I think it is pterygo tympanic, pterygotympanic fissure, I think. Let me don't quote me on that. And it ultimately in the infratemporal fossa it fuses with the lingual nerve and it gives parasympathetic supply to the mandibular division and mandibular and submandibular and sublingual gland, and it gives taste fibers to the anterior two-thirds of the tongue. That is very commonly asked. And then after emerging from the sternum straight foramen and before reaching the parotid gland, it gives rise to these branches: posterior auricular branch, muscular branch, and they supplies these muscles. Or posterior auricular branch supplies these muscles, muscular branch supplies these muscles, and within the parotid gland, it gives rise to further five branches, and these five branches supply all of the muscles of facial expression, including the platysma. So here the question was last intracranial branch of facial. So intracranial branch was this one within the facial canal, and the last one is this one, chorda tympani. As chorda tympani was not in the answers options, the best one to go, the next best one was nerve to stapedius. I strongly suggest you read facial nerve in detail, parotid surgery, facial nerve muscles affected. Here I have an objection. Buccinator muscle, that's very nice. Buccinator muscle is being supplied with a buccal branch of the facial nerve like this. But platysma is also partially correct. But again, you can give preference to the buccinator. It is the muscle of facial expression and it's present in the cheek. But still, I think it's a poor recall. The right vagus nerve, it's about the vagus nerve. It travels along. You should know that it is basically a question of thorax mentioned here. The right vagus nerve, it is passing near the trachea. You can see here. The left vagus nerve does not passes near the trachea because it is separated by aorta and subclavian artery and the other branches. Phrenic nerve avulsed right at the origin. Phrenic nerve, whenever it will be affected, there will be loss of um, diaphragm functional loss. So there will be ipsilateral diaphragm paralysis just at the origin. And loss of sensation in the central part. This is not completely correct because the central part of the opposite side will be a functional sensory component. So loss of inspiration, it's not completely correct because one half of diaphragm it will be at least working. So ipsilateral diaphragm paralysis. Ipsilateral paralysis. Ansa cervicalis, it's one of the cervical plexus, and ansa cervicalis is found by C1 anterior limb from the hypoglossal nerve and C2 and C3 then forming the posterior limb. You can see that C1 fibers they become a part of hypoglossal nerve and from then they separate to form the anterior or superior root, and C2 and C3 they form the posterior or inferior root. Inferior thyroid artery is a branch of it's merely a point of remembering. It's a branch of thoracocervical trunk. Thoracocervical trunk has a lot of other branches you should know, including ascending cervical and transverse cervical, suprascapular, and so on. Inferior thyroid artery is the branch of same question. Middle meningeal artery is a branch of review. Snell has a very good concise explanations at one point. Middle meningeal artery is a branch of maxillary artery. It is not in this particular picture, but you should know that. Jugular foramen, internal jugular, after coming out of the foramen, it is relation with. You can study that in the topic of internal jugular vein and its relations. Immediately after emerging from the skull, its anterior relation there is internal carotid artery. It's just present anterior to it. Middle thyroid vein, intends into internal jugular vein, submandibular nodes, both are enlarged. Some site of primary malignancy. Here again, it's not a very good constructed MCQ. And a very good answer candidate could be tongue, as the tip of the tongue is in the submental and sides are into the submandibular nodes. But here lower lip, so the middle part in front of the incisors is being supplied by submental and the sides by submandibular. So both are the good candidates. What to choose? The better option is the lower lip. because lower lip is only being supplied by these two nerves, lymphatics, submental and submandibular. The tongue itself is also being supplied by the deep nerves also. Okay. So this is the preferred answer. You can see that tongue is being drained by submental, submandibular, and directly deep cervical, whereas the lower lip is being supplied by these two only. Jugular-digastric lymph node drainage. It drains the palatine tonsils. Jugular-digastric node drain palatine tonsils. Again asked. Now the questions of the pack. Lumbar triangle. Lumbar triangle is asked a few times. Lumbar triangle is this one. You can see here, this one, this point. So anteriorly there is external oblique. Posteriorly there is latissimus dorsi, and inferiorly there is iliac crest. So it is anteriorly bordered by external oblique. Lumbar triangle, again this is asked from another angle. Anterior border, it is bounded anteriorly by the posterior border of external oblique. The same question asked a little differently. Spinal anesthesia, anesthetic agents in which space? Again, this is a not very nicely formatted question because subepidural and subarachnoid spaces both can be correct depending upon the type of anesthesia you are given. But lucky, here subarachnoid space is the most common one, so you will follow that because mostly the spinal anesthesia is given to the subarachnoid space. Whenever there is a say, anesthetic solution to the epidural space, it is usually mentioned epidural anesthesia. It is not simply said as spinal anesthesia. So whenever spinal anesthesia, go for subarachnoid. Again, remember the layers. The lumbar puncture after at L4, L5 after intralaminar space comes. Again, the layers after ligamentum flavum, laminar space, there is epidural space. And vertebral bodies are limited by vertebral bodies are bracketed by anteriorly there is anterior longitudinal, posteriorly there is posterior longitudinal vertebral ligaments. See here you can see the anterior longitudinal and posterior longitudinal ligaments. So this is the end of the questions that are relating to head and neck in the Golden 9 Medicine and Allied paper. For follow up, follow our Facebook page and our YouTube channel. If you have any further question, suggestions, and objections, be sure to mention in the comments below. Thank you so much. Allah Hafiz.